First case, Monica, medicine over the other.
I'm presenting on behalf of Medicine 3. Mr. R, 21 years old, who is on continuation phase of ATT, started in view of meningitis, presented with absent verbalization from morning and increased dependence of activities of daily living since 1 month. There is no history of increased weakness of limbs and no history of headache, loss of consciousness, vomiting, or blurring of vision. Events, one contributing to other. On 2022, he had a history of cough for 6 months, which is diagnosed as sputum positive pulmonary tuberculosis, and ATT was started. After 2 months of treatment, patient becomes a defaulter. On March of 2022, he was diagnosed to have TB meningitis and started on ATT. Again, on August 2022, he presented holocranial headache, vomiting, diagnosed as hydrocephalus, and treated with ventriculoperitoneal shunt. And after that, we have started him on steroids up to October. There is history of incompliance to steroids in between after his second presentation. On examination, his respiratory rate is 20 and SpO2 of 98%, and pulse rate of 112, and GCS is 10A and 15. He's icteric, and systemic examination, CVS RS per abdomen normal. On central nervous examination, he has bilateral pupils 2 millimeter and equally reactive to light, and there is a deviation of angle of mouth to the left side, and he also has a gaze preference to the left side, absent gag reflex bilaterally, and not able to protrude tongue. And he's normotonia in all 4 limbs, and his power is in the upper limb and lower limb bilaterally 3/5, and deep tendon reflexes are normal. And left side there is angle clonus and knee clonus, and plantar bilateral extensor. A sensory system could not examine because the patient is mute and patient is aphasic at the time of presentation, and meningeal signs, minimal terminal neck stiffness, and spine and skull are normal. The symptom complex is he is a known TB meningitis on ATT with the new onset weakness, which is aphasia, and there is a non-improvement in general condition. So the differentials for the non-improvement even after ATT can be like complicated TB meningitis. His hydrocephalus can be worsening, or endarthritis with multi-infract state, or basal exudates, or tuberculoma. And it can be due to non-compliance of medication or resistance to ATT drugs, or immune reconstitutive inflammatory syndrome, or paradoxical worsening. So his investigation HB is 13.4, WBC of 7,300, 58% neutrophil, platelets normal. Electrolyte wise, his potassium is 3.3, LFT, RFT normal, and calcium phosphorus is 8.90 and 4.1, and he is HIV non-reactive. The line probe assay done at the first time of admission on March is now has grown and shown as rifamycin susceptible and isoniazid resistant. And we have done an MRI on 23/11/2023, which showed multiple ring enhancing lesions in perimesencephalic, peripontine, premedullary, left CP angle, and along the left foramen of Laska, causing mass effect on midbrain and parts, and acute infractal left putamen and insular region. This is his MRI. Final diagnosis, tuberculous meningitis, paradoxical worsening, and isoniazid resistance. So he has like multiple new tuberculomas, but all of them are adjacent to where there was meningitis in the previous MRI. So it could be worsening of previous lesions, and so it's known as paradoxical worsening. And his lacunar infrax does not explain the global aphasia he has, and his activities of daily living are grossly out of proportion to the lesions in his brain. Treatment. So as he developed isoniazid resistance, in place of isoniazid, levofloxacin was added, and as he is in the continuation phase, he's on pyrazinamide, which was changed to ethambutol because ethambutol is found to have a better CNS penetration, CSF penetration. And he also started on tablet dexamethasone 4 milligram daily. And after that, we treated him with infliximab, and So we are going to see what's the role of infliximab in iris or treatment paradox. It's called as treatment paradox because tumor necrosis factor is critical for effective host defense mechanism against mycobacteria. So monoclonal antibodies that inhibit TNF alpha, such as infliximab, will greatly increase the tuberculosis vulnerability. But in iris, we are using infliximab to treat the condition. So on the other hand, deterioration of tuberculosis patient after infliximab cessation suggests that TNF alpha also contribute to disease pathology. So this use of infliximab to control paradoxical reaction in a patient with tuberculous meningitis was first demonstration in 2008. So this is the article. It was came in 2021 because it's used in like right from the 2008. It's used in many places. So after the first dose of infliximab, the patient follow-up in OPD. On admission, he has a gaps and gag, but in OPD visit, gag is present and he's taking food orally. And on admission, he's not able to protrude tongue. Now able to protrude tongue. And power is 3/4 in the 3/5 in all four limbs. Now it is 4/5 in all four limbs. And the clonus which was present is absent now. And from aphasia, he is now able to say his name. And he also walks with support. And this modifier ranking scale is also changed to 4. And we are planned to give him second dose of infliximab after 1 month. We gave together.
We gave together. So how many doses of infliximab are we planning?
Based on the response, we are planning.
So if a patient has TB and you have done a retroviral test and it has come positive, so which one would you start first? Is it ATT or ART?
ATT, ma'am.
You want to start ATT. And when do you want to start ART?
After
what is
2 months of ATT.
Do you want to do any other test before deciding when to start ART?
We can do CD4 counts.
Depending upon it, you will decide when to start. Any other questions?